Welcome, everyone, to today's webinar, How Jefferson Health Turned a Capacity Crisis into an Opportunity with Virtual Nursing. On behalf of Becker's Healthcare, thank you so much for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. If at any time you have trouble with the video or audio, try refreshing your browser. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. And all submitted questions will be shared with our sponsor following the presentation. With that, I am pleased to welcome today's speakers, Colleen Malazzi, Senior Vice President, Chief Nursing Informatics Officer at Jefferson Health, Laura Gartner, Division Director of Clinical Informatics at Jefferson Health, and Lizbeth Votruba, Chief Clinical Officer at AvaSure. Thank you all so much for being here today, and I will now turn the floor over to you.
I'm Lizbeth Votruba. I'm the Chief Clinical Officer at AvaSure, and I've been a nurse almost 30 years and have been an industry nurse executive for the last 8 years. And I'm very excited to have this conversation today with my colleagues and friends from Jefferson Health. I wonder if we could each take a moment to talk a little bit about your background and roles. Let's start with you, Colleen.
Thanks, Elizabeth. I'm Colleen Malazzi. I am the Senior Vice President, Chief Nursing Informatics Officer for the Jefferson Health System. I have been at Jefferson for about 9 months and have been a nurse for about 13 or 14 years. Prior to my experience here, I was at Penn Medicine, so I spent time in the Philadelphia area working in nursing informatics as well, and really learning about how we deliver care in the Philadelphia region. And Laura?
So I'm Laura Gartner. I am a nurse by background. I've been a nurse for about 19 years, all at Jefferson. I still pick up time as a rapid response nurse on the weekends, but my primary role these days is as one of the clinical informatics directors at Jefferson. There are 4 of us. And I did leave my full-time bedside job about 10 years ago to pursue a career in informatics, mainly because I really want to make things better for our nursing staff, make them more efficient so that they can spend time doing the important stuff and not worrying about their documentations and things along those lines.
Okay, great. We have an interesting story to tell, and there's a background to how this all began, and then we're going to get around to ultimately some outcomes from the implementation of virtual nursing. But I'm wondering if you could kind of share with everyone how this all began.
So virtual nursing was something that was already on our radar, but this past fall and winter, the ball really got rolling because we were preparing for a surge in pediatric patients due to RSV, influenza, and COVID. And so with this anticipated surge coming up, we pulled together a team to talk about piloting virtual nursing. We found out very quickly we needed to notify the Department of Health for this new technology we're using. So we submitted that. And in the meantime, which of course that was definitely slowed us down a little bit, the PED surge thankfully did not occur like we expected. So we had higher volumes, but not in the way we anticipated. And we took that opportunity to pivot our pilot to focus on med surge units.
And that is something unique to, I believe, the Pennsylvania Department of Health. You were talking about that a little bit, and it was about implementing new technology and vetting it through the Department of Health.
That's my understanding. So we had to submit a notification and then wait for their approval. So they have 60 days to provide that approval.
Mm-hmm.
Yeah, so that's how it's kind of interesting story, like having a strategy of getting towards virtual nursing, but something occurred unplanned that prompted you all to speed it up. And yeah, Colleen?
It did. And I think what's wonderful and unique about Jefferson is that we span multiple states. So we're constantly trying to figure out and evolve with the different processes. So in this case, the Pennsylvania Department of Health had some different needs for submission than the New Jersey Department of Health, which we were also trying to implement for one of our pediatric units. So this has been a very iterative process where we've been able to learn along the way about what are the different needs and how do we plan for the future. And something about virtual nursing, which I think gives us great hope, is should there be another pandemic, we're going to be in a better position and more prepared for it. So I there have been hiccups along the way, but having good partnership from our vendor and working closely with our regulatory teams helped us to overcome some of the challenges that we didn't know were going to be presented through this process.
Absolutely. That's just reality. Colleen, I think we both come from generations of nurses. I'm third generation nurse. I believe we talked about that for you too. And now you're in the role of Chief Nursing Information Officer. And tell us a little bit about that role and how it's structured and how it's been important in this implementation.
Sure, I'd love to. Yes, I have nurses in the family. I have clinicians in the family. So it was important for me to evolve from my initial degree was in information systems and computers. So I eventually took on a secondary degree in nursing and haven't looked back. What I've had the joy of doing is putting both of my degrees together and really figuring out and evolving with changing healthcare to what is nursing informatics, what is clinical informatics. So my job as the Chief Nursing Informatics Officer is really unique in that I have a dual reporting structure to our Chief Nurse Executive, Dr. Kate Fitzpatrick, and our Chief Information and Digital Officer, Nasser Nizami. I didn't know what to expect with a dual reporting relationship, but truly it has empowered, I would say, the voice of nursing in the discussions related to technologies. I partner with clinical and operational leadership to help define the needs and then align with IS&T to make sure that we are getting the best in breed technology, setting our appropriate timelines, and then hitting that kind of innovation and transformational approach to implementations. So it's really been, it's the right structure. It's the right way to approach nursing informatics because I sit within the executive nurse leader cabinet, and I also sit within the CIO cabinet and really have the voice of the nurse at the table. Laura and I say it constantly, but we will never be making decisions for nurses without the voice of the nurse represented in the conversation. We are not trying to pretend that we know what it's like now, today, in 2023, to be a med-surg nurse or a labor and delivery nurse or a trauma nurse. They have to tell us what it's like, and then we help figure out the right technology to support them.
I think that's been interesting from my perspective to see how that operates at Jefferson Health, and I really appreciate it because I think what has happened, or there's a pitfall in historically, if there isn't a liaison in the translation between the clinical and technology, either things get lost in the translation or the process and the timelines are at risk because clinicians kind of tend to make decision making one way, maybe kind of the scientific method or the evidence-based practice model, and then technology has their own strategy roadmap that they're looking holistically across the organization. And when the intervention involves technology, it's just so much smoother and more effective if you're working in parallel and have that voice.
It does, and it combines the knowledge of patient care with the knowledge of our project management groups and our technology. We have had such great stakeholders involved, and Laura and I can talk through the team that helped us and is helping us to implement virtual nursing, but it really takes a village, if you will. We all have different expertise, and it's important to recognize where we have gaps and where we have opportunities and to lean into that expertise.
Yeah, so let's go back to last fall. The CDC numbers for RSV were frightening. The curve was going up like this. Yeah. So, and you all decided that in order to support pediatric care, that virtual nursing pilot needed to happen quickly. Who did you all decide to pull into the team, and how did you set up that structure?
Again, I was new here, so I got to ask lots of questions about who and how do we work with this person. So I think some of the really important stakeholders, one of our leaders within the IS&T organization, Ed Dell, has been really an incredible partner with us to figure out contract negotiations and interoperability between our existing systems and what we were hoping to do. And then just things that we may not be thinking of. What's the wiring look like? What does the Wi-Fi signal look like? Certain things that, we know that these are on the list of considerations, but they're really important when you're trying to spin something up quickly. Some of the additional ones were our nursing operations leaders. So Daniel Hudson, Andrew Thumb, they really helped us to map out what is the impact to our workforce? Where are they going to need help in this type of situation? And then how can we kind of decant some of the responsibility that they have so that they can care for this surge in pediatric patients? It has been such an important partnership to be able to work with them, thinking through what's the ROI on this as well. So we have an emergent need, but this is still a business. So how do we implement this and have an appropriate leveling in the amount of money that we're spending to reach the outcome that we need to do and support nurses at the bedside? Or who else?
So frontline engagement was really key. So we pulled in the directors and nurse managers, as well as some key people for the pediatric units, and then later on the med surg units. So the charge nurses, people who were really invested in this project being a success. I'd also say our EHR team, our analysts, have been very key in making workflows in electronic health records support the virtual nurses and the bedside nurses. So although most of the documentation occurs where it normally does, we do have some optimizations to our EHR that have been really helpful in helping the communication between the bedside nurse and the virtual nurse.
And on our end, we have kind of a team that helps with implementation as well. And 15% of AvaSure are RNs. So we have a RN implementation specialist and project manager and technical support. So there was a regular cadence of meetings that also included at the executive level. So Colleen and I were often on these calls as well. And that was a great experience for us as well to work together on something on a shorter timeline.
And I can applaud you all enough for the support that you offered us. This was not, everyone kind of dropped all the normal rules and stepped in and said, all right, how do we make this work? This is an important thing that we should try to do together to support this potential surge. And we really appreciate the support that you guys offered to help us design this, implement this, roll this out in such a timely manner. Even though we ended up pivoting to adults, it still allowed us to implement something more rapidly than we would have been able to.
It was we were all kind of on board with the mission, and then we had put in so much work and we had this great structure in place. So we did pivot. We did pivot to adults a couple months in, which was a relief that the RSV surge wasn't as bad as it looked like it could be. Let's talk a little bit about the role of the virtual nurse. So this is the nurse that is remotely interacting with inpatients. And how did you select and train those nurses? And what did you learn that maybe others could learn from who are on the webinar?
So for us, the virtual nurse is another member of the care team, and that this nurse is not meant to replace the bedside nurse, but more meant to supplement the care and work together with a virtual nurse so that we do everything we need to for our patients. Virtual nurse can do anything really that doesn't require physical touch. So for our pilot, there's been a huge focus on admission and discharge education and paperwork, as well as purposeful rounding and some other checklists and things along those lines. In terms of training, we're kind of learning as we go. We recruited the two nurses based on licensure and experience. So as you recall, we started with peds. We needed to find nurses who had pediatrics experience. And we also needed somebody or a virtual nurse who had licensure for not just Pennsylvania, but also New Jersey. And so that definitely narrowed the playing field down quite a bit. But we were fortunate to find two awesome nurses who are part of our enterprise resource float team. And they jumped in, just like everybody else did for this project. They jumped in with a willingness to learn and be agile and flexible and things along those lines. And we also needed to consider training the bedside staff and how they're going to deal with this virtual nurse. But it's been a learning experience, but a really rewarding one to find the different ways to communicate with people and teach them things.
people may have missed it when you did your introduction, Laura, but you still take shifts as a rapid response nurse.
Yes.
And so what an amazing perspective that brings to this planning and probably relationships as well. So thank you for doing that. I didn't know how you made the time, but I think that's probably key to getting that engagement and understanding the role from the bottom up too. Sorry, Colleen, were you going to add something too?
No, I want to echo your sentiments to Laura. She, I don't know that she sleeps very much. She is a very hardworking person, and I love that she continues to practice.
Yes.
Something related to these virtual nurses, I would say adaptability is a word that has stuck out a lot since we started. Virtual nursing is not well defined. What's the role of the virtual nurse, and how do they take some of those admission type, administrative type functions off of the bedside nurse? How is it not a threat? So we've had to overcome some of these things as we learn about how does a virtual nurse function? How are they really a co-care model with the bedside nurse? And it's been very interesting, and we can definitely speak more about it. But I would say that's been some of our biggest learning points, as you don't go to school right now to be a virtual nurse. So we learn in school how to be a bedside nurse, how to care for a patient. But virtual nursing is now new and evolving, and I think there will be classes and training in this space as we go forward.
Yeah, there's definitely a different skill set in communicating with somebody via a two-way camera versus sitting right next to them. And there's certain things that you might use as a bedside nurse, physical touch, when you're communicating with a nurse, or the patient, that you can't as a virtual nurse. So it's definitely some skills we've had to kind of learn along the way for our virtual nurses.
Yeah, virtual nursing in the med-surg space is very emerging role right now. I think there's been more in the virtual ICU setting, but a virtual nurse with the patients aren't the high acuity of critical care anymore, and are more like directly interactive one-on-one with patients and going through admission, discharge, education. And so I'm really pleased that there are resources coming available for this. I'm on the task force for the Academy of Med-Surg Nurses, and they are writing a certification on this right now and should be available in the summer of 2023. But kind of defining the domains of virtual nursing, including, like you implied, Laura, website manner, and then also the prioritization and working with the bedside team, and a lot of critical thinking. And sometimes I hear something like they take the low end tasks from a nurse, and I don't like that at all as describing the virtual nursing role. It is some of the highest level critical thinking, patient interaction, responsibilities and nursing interventions. It's really practicing within the scope of nursing in a different way. Yeah.
And that has been something that came up where the bedside nurses said, well, I use the admission assessment to understand who my patient is, who their family is, what their needs are. So we have to find a way to let the virtual nurse do that from an administrative standpoint, but then tell a story to the bedside nurse about who that patient is and what their needs are. So that's the piece that we're trying to figure out, is how do we have a back and forth between our virtual nurse and our bedside nurse to make sure that that story is handed off, but take that administrative piece off of their plate.
Excellent. So we had kind of implied that it started with pediatrics and then we shifted gears. So Laura, maybe you can kind of describe the setting where you ended up going live with virtual nursing.
So the units that are part of our pilot are two sister units at one of our hospitals in the health system. They're in two different buildings, but they do have the same nurse manager as well as the same staff go between the units. And they primarily take care of patients in observation status. So there's a very high turnover of patients. It's quick getting admissions in, but also there's a big focus on getting patients out as well, getting them set up for their transition of care. We have 23 cameras. So we have one of the units is fully saturated with 12 cameras because they have 12 rooms. And then we have about 30% of the other units with cameras in each room. So there's 11 on that unit.
And aside from the high turnover of patients, what were some of the factors that you took into consideration to decide that this was a great unit for piloting?
Well, there's really been, there's kind of a variety of things. I will say some of it was chance, but there's a very engaged nurse manager for this unit, and she and her staff were already very interested in virtual nursing. They had seen something somewhere and had already brought the topic up. So that was perfect. There is a huge focus on length of stay right now, and this unit is one where we can make a huge difference in getting people out the door quicker or up from the emergency room fast as well. Colleen, I don't know to add to that.
I think that pulling from the emergency room is one that sticks out in my head. There has been a big surge to the emergency departments as well over the winter months, and I think that it brought a lot of attention to observation status patients and how do we treat them, how do we prepare them to either go home or be admitted. And we've really seen great impact on being able to pull patients from the ED. No one wants to sit in an ED. No one wants to be in the hospital necessarily, but this has really allowed us to get them to the right level of care more quickly, which has good outcomes for our patients.
So throughout this process, could either of you share with us some of the lessons that you learned that might be helpful for those who are listening?
So there were a lot of decision points we had to make while we were designing this pilot. So for example, mobile cameras versus fixed devices. The cameras we're using are mobile. Does that mean that we move them in and out of rooms to cover every admission for that unit, or do we keep them parked in a room? And we opted to keep them stationary in assigned rooms. And this has allowed us to do things like that purposeful rounding. So you wouldn't be able to have a virtual nurse purposely round if a bedside nurse or someone on that unit was going to have to move those cameras in and out of a room. And we think that this was another satisfier for the staff, because they were initially worried that it was going to take time away from them to bring a camera into the room and then take it out and clean it and things along those lines. The other thing that's come up quite a bit is how you staff for a virtual nurse. Do you have someone from the unit be part of the virtual team, someone pick up extra time? Do you take a nurse who's been retired? And I can't say that we have all these answers, but we have found that there's different skills that a virtual nurse might need, so that you do need to take those into consideration. And then the other thing that's come up is, where does the virtual nurse sit? Do they sit on the unit? Do they sit in the hospital but not on the unit? Do they work from home? And for our model, which may or may not be the right answer, they are working from a central location in the hospital. So they don't go up on the floor. The goal is for them to work virtually, but they are on site working from a station where we had some room for this pilot.
Yeah.
And the reasoning for them not being on the unit is because there's a great opportunity that they would get pulled into clinical care on the unit. So we like the idea of having them not on the unit, but are trying to think forward about how we provide opportunity. Would this be a great thing to offer to our bedside nurses to say, hey, why don't you take one shift a week as the virtual nurse? I don't know. We have to evolve again with the technology and with our training in this space, because that could be hard to train people about how to be a virtual nurse. It's a unique skill set we're finding. So we're going to learn as we go. But in the expansion, we'll have to figure out, is this we hire outside of our roles and they focus just on virtual nursing, or we allow people the opportunity to work in this space on top of being a bedside nurse?
Yeah, I see pros and cons of both ways.
Me too.
So yeah, thank you for sharing those lessons learned.
Yeah.
And what I've noticed, and this has been a lot of serendipity as we pulled this together, but the nurse scientist in me, I'm not a nurse scientist, but I do like working with nurse scientists and understanding outcomes at a very rigorous level. So as Laura described it, across these two care units that are in separate spaces and separate buildings, but similar type of patients, similar leadership, and it seems like roughly half of the beds are part of the intervention, and that leaves half that are control. So as you get towards outcomes and measuring the impact, it's a lot more rigorous than pre and post studies. So we kind of have this built-in intervention and control group, which is kind of exciting as we see outcomes emerging. I don't know if you planned it that way exactly, but
We didn't.
let's say we did.
Let's say we did. And the only reason that I would say that we didn't is because it came down to space and certain rooms that were private and certain rooms that weren't. So as we were rolling out, we felt like it might be easier for acceptance of technology for our single rooms to allow the camera in there to have those private conversations. That doesn't mean we won't evolve to have cameras and virtual nursing within our dual rooms. But it just worked out that way, that the number of cameras we had aligned to the one unit's private room.
And so let's talk about when you ended up going live, and then some of the process metrics that you've been capturing about as we've been live for a few months now.
So we went live March 1st. We got approval from the Department of Health in February, and then chose March 1st because everything was in place, all the education was done, the equipment was here. So we started off with 5 patients with our virtual nurse, and then quickly scaled up to the 23 within that first week.
And you were measuring the types that you talked about some of the types of visits. Can you talk through what has ended up being the most, I think, helpful types, whether it's admission or discharge, and what's involved in rounding, and any surprise types of ways that nurses were able to help patients that you hadn't thought of?
The nurses on the bedside nurses loved the admission, education, and paperwork being done. That has definitely been a big satisfier. We've seen the discharges go really well as too. And then the purposeful rounding, and we've tweaked the purposeful rounding to instead of just saying, okay, you're going to round every hour, we've given our virtual nurses a schedule so that the bedside nurses can anticipate when the virtual nurse is going to pop into the room to round on the patient. And so then the bedside nurse gets those other hours. Since we've started, we've had we found a few things that people really enjoy giving the virtual nurse to do. And one of those is our MRI checklist. It's a pretty lengthy checklist, and these 2 units do send quite a few patients for MRIs. So it's been another big staff satisfier.
I'm just remembering back in my days of the MRI checklist, and it was, something I like, like, oh man, there's so many questions, but also there's the impact of full utilization of the MRI and getting them down in an efficient manner, and then that probably impacts discharge too.
Absolutely.
Yeah.
I think in our first day of rolling out, Laura, correct me if I'm wrong, but we had a patient who was NPO waiting for either a procedure or surgery, and the virtual nurse was doing purposeful rounding and popped in, and the patient was about to, eat a snack, and they said, well, you have a procedure, and we want to make sure that you don't eat prior to that procedure. We're so sorry if something was delivered or if someone brought you something. But they were able to intervene, and that would have been a delay in care. It would have been a delay in their procedure, and then an extended stay for them. So it was really, that first day was a nice aha moment for us to see, like, this is important to be able to pop in to see our patients. And we do get caught up in our tasks, and you can have 5 or 6 patients that you are focusing on as well. So it just provides this additional level of oversight, which I think is a really good, again, co-care model where we're partnering on caring for the patient.
And on the purposeful rounding, are there some elements in there, specific elements that they go through?
So we have put together some scripting for the virtual nurses. So they start the day off with their first set of rounding. They introduce themselves, they reiterate their role in the care team. And then, as with any rounding, they look at the P's, do they have things they need? Do they have any pain? Things along those lines. They can do a safety sweep or a virtual sweep of the room to make sure there's no barriers in the patient's way to the bathroom and things like that.
Okay, that makes sense. And then I know you were looking at length of stay. And can you talk a little bit about which aspects of length of stay you're measuring as part of your KPIs and what the impact has been so far?
Sure.
So length of stay is a hot topic around here. We've been
Mhm.
specifically looking at not just length of stay in hours or days, but can we impact pulling patients up faster from the emergency department as well as discharging them quicker? So measured from the discharge order goes in and how fast does the patient leave the building after that point? And we've seen some promising trends for both of those, I believe,
Mhm.
but specifically that discharge order to discharge time.
Excellent. And you talked a little bit about the ability to pull from the ED. Is there anything specifically that you're measuring there?
So you can look at when the decision to admit, that's one of the time points, but what we're looking at specifically is when a bed is assigned to when the patient arrives to their head in the bed to when they get to the unit.
Bed assigned to head in the bed.
Mhm.
Okay. Great. And then you had mentioned the nurses love it, the help with the admission forms and I'm sure the MRI checklist. And what is your initial feelings of or observations about patient experience?
We've heard good things from the patients. We do have a survey out there for the patients that we haven't pulled the results together for yet. However, we found that some of the patients really enjoy having that not company, but someone to spend more time with them doing that admission and then popping in, during the day, and they have time to provide some education and answer questions.
Yeah, I've heard that from elsewhere also that the virtual nurse is less busy and less interrupted than a bedside nurse who might have to run out and answer or respond to an alarm or answer another call light. And so I've heard anecdotes, and it's not from Jefferson but from another health system, that the patient said, oh, I feel like I can confide in you because my bedside nurse is super busy, but you're not. And so I'm gonna, tell you the fuller story or ask the burning questions. So
I also think, Lisbeth, that there's a promise here. If we can take
Yes.
some of that additional workload off of our bedside nurses, then they can spend more time having thoughtful interaction with the patients, with their families. And I truly, that's what we're hoping for. This isn't to then give them more work. We're really hoping to return some time to the nurses so that they can focus on that thoughtful care delivery, eye contact and other things that can be hard to do when you're entering a lot of information into a computer or trying to keep up with your documentation.
Oh, I love that hopeful perspective. And that's kind of how I feel in just working in many areas to transform nursing right now and to leverage technology to help us and support. And I am hopeful for the future of nursing that we will embrace again, like we always do, change and transformation and continue to keep the joy of nursing at the forefront, as well as patient care and the whole, holistic patient care. And that's why we all went to nursing school. So I just want to give you each a moment to talk about your hopes for the future for virtual nursing. Do you want to start, Laura? Any last ending thoughts about virtual nursing in the future?
So I might have been a skeptic in the past, but I really think there's such a role for a virtual nurse to work alongside the bedside nurse. And, just the small successes we've had so far provide this really great foundation for us to do even more with this. There's so much we can do for our nursing staff. And we talk quite a bit about how this can help take care of our patients, but I really do feel that virtual nursing is another way for us to take care of our nurses as well. And that's really important in this time.
Very well said, as always, Laura. I echo everything that Laura has said. I want to continue with this mantra of thinking differently. Coming out of the pandemic, we have to do things different. We have to think about healthcare delivery differently. We need to utilize the resources available to us and evolve with the changing technologies. I am a big, huge believer in that clinical and operational pathways should drive the technology and not vice versa. So I think in virtual nursing, we're at the forefront of how we utilize technology in the acute care setting. And there's a lot of opportunity here. Think virtual case management, think about that pastoral care that can't come in from the community, but can connect with the patient. Also our physician consults utilizing the same platform. So I think that we are going to be the tipping point for how we do this differently in an acute care setting. And it's not telesitting and it's not EICU, it's a whole different model of care for a med surg population for those medicine patients. So it's exciting. I am hopeful the same way that you are, Elizabeth and Laura, and I think we have a really great opportunity here to change the way that we deliver care going forward.
Thank you both. This has been a wonderful conversation, and thanks for your generosity to share what you've learned so that others can, jump forward on the same process.
Absolutely. And thank you for the partnership. We've had such a wonderful experience working with you guys.
Us too.
Yeah.
That is all the time we have for today. I want to thank Colleen, Laura, and Elizabeth for an excellent presentation and AvaSure for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console, and don't forget to fill out our post-webinar survey. Thank you for joining us. We hope you have a wonderful day.